Good morning, everybody, and welcome to a new year in Grand Rounds. It is my distinct pleasure to introduce our first Grand Round speaker of 2024, Dr. Margaret Distler. Margaret is truly one of a kind. She is an accomplished clinician, educator, and researcher who has been nothing less than consistently impressive as long as I have known her. She began her medical career by obtaining an MD and a PhD from the University of Chicago before coming to UCLA in 2014 to do residency here. I got to know her well throughout the 4 years of residency training that we shared, and I've been fortunate enough to count her not only as a colleague, but as a friend in the years since we both graduated in 2018. She joined the faculty here right after graduating and now serves as the director of both the UCLA Anxiety Clinic and the medical director of the UCLA Aftercare program. In addition to her uncountable strengths in academic medicine, Margaret is simply a joy of a human being to be around. One of my favorite memories with her was our very last day of our second year of residency when I was on a rotation. We finished up rounds and got all our work done. And then to celebrate, Margaret suggested taking a dessert tour of Westwood, where we stopped and got amazing treats from lots of different shops in the area. It was just the perfect way to end the year and really a perfect encapsulation of the joy and the spirit that Margaret brings to everyone around her. So today she will be giving a practical clinical update on the use of benzodiazepines in clinical practice, and I hope that you'll join me in welcoming her this morning. Margaret, handing over to you.
All right, thanks, Jonathan. Such a very kind and generous introduction. I really appreciate it. I'm very honored to be here, and Happy New Year to everybody. Let me share my screen. So today I'll be talking about clinical applications for benzodiazepines, particularly in psychiatric practice. And we'll talk about the evidence for benzodiazepines, specifically for anxiety disorders and insomnia. We'll also identify alternatives to benzodiazepines, as well as the risks of their use in these applications. First, we'll start with a very brief, I promise, just one slide overview of the mechanism of action of benzodiazepines and their clinical uses. We'll go into a case study and then talk more about the evidence base for using benzodiazepines for anxiety disorders and insomnia. We'll also touch upon their limitations. I'll give you some pointers on deprescribing benzodiazepines, and we'll wrap up with our case study. So here's the one slide, I promise, very brief review of benzodiazepines and their mechanism of action. So they act at GABA-A receptors, and all of you probably remember that GABA is our primary inhibitory neurotransmitter in the central nervous system. And benzodiazepines act at these GABA-A receptors. They cause membrane inactivity, which causes the cells to be harder to activate and are thus inhibitory. They're inhibited, and so benzodiazepines cause neuronal inhibition. And we see GABA-A receptors distributed widely throughout the CNS. And as such, benzodiazepines, through acting at GABA-A receptors, are widely thought to be inhibitory. And because of this broad use, they can be applied for FDA-indicated purposes like anxiety disorders and insomnia, as we'll talk about, as well as seizures and status epilepticus, and pre-medication for anesthesia. Again, because they are so broadly applicable, we also see uses for agitation, alcohol withdrawal, muscle spasms, sedation, other sleep disorders aside from insomnia, and catatonia. So today we'll talk about just the psychiatric applications, and I'm focusing on actually the most debated, most controversial uses, which would be the anxiety and insomnia realms. Let's start with a clinical case to kind of anchor us in our conversation. So this is actually a personal patient of mine. She's a 35-year-old Caucasian woman with a psychiatric history of depression in partial remission and multiple comorbid anxiety disorders, including generalized anxiety disorder, social phobia, specific phobia of driving, and PTSD. She's coming in for treatment of her treatment-refractory anxiety. Her current symptoms at the time of presentation included frequent worry, muscle tension, restlessness, poor concentration, insomnia, low energy, and difficulty relaxing. She was not affected by low mood or anhedonia, so that kind of rules out active depression. She didn't have re-experiencing symptoms related to her PTSD. She was driving regularly for work, so symptoms of PTSD and her specific phobia were inactive. And although she did have some social concerns, she didn't have social avoidance or impairment. She was meeting with her boss one-on-one and not finding any problems at work. She doesn't use any substances. And so basically the formulation here is a patient with depression and multiple anxiety disorders presenting with treatment refractory GAD. Her GAD-7 score at the time of presentation was 18, and she was taking fluoxetine 20 milligrams. She had partial benefit, mostly for mood, with some benefit, but incomplete for anxiety. And she was taking diazepam 5 milligrams as needed. This was partly beneficial, but she used it sparingly for a couple of reasons. The first was that she was just kind of worried about the stigma related to taking a benzodiazepine. She did not want to become dependent, and she didn't like how it sounded to be on a benzodiazepine. And she also was considering pregnancy and did not want to be on a benzodiazepine during pregnancy. Let's review her treatment history. I won't go through all of these, but some of the highlights that she tried numerous antidepressants. As I said, she's currently taking fluoxetine. She had tried a higher dose up to 80 milligrams, which was importantly not any superior to 20 milligrams that she was presently taking. She had tried several other SSRIs and non-SSRI antidepressants that were either ineffective or had side effects. She tried pregabalin with partial benefit, but intolerable side effects. And her benzodiazepine history included lorazepam, which was helpful, but she had interdose rebound anxiety. And the diazepam, as I mentioned before. She had failed augmentation of her antidepressant with atypical antipsychotics. Lorazepam and aripiprazole were ineffective, and the quetiapine, although partly effective, had side effects. Here's a list of some of the other medications that she had tried. And importantly, she had also tried neuromodulation techniques, including ketamine and TMS, both of which were partly beneficial for her mood, but not for anxiety. She had also completed a year of cognitive behavioral therapy and was, at the time of presentation, in supportive psychotherapy. So as you can see, this is somebody who had tried many different medications. Her past medical history was significant for some autoimmune disease, hypothyroidism, and infertility. She did not have any history of substance abuse, and she was functioning well in her occupational and social life. In terms of her treatment, given the numerous trials of medications and the lack of response or significant side effects from previous agents, we made the decision to increase her diazepam to 10 milligrams twice a day standing. And after this presentation, we'll review how she did. So let's launch into discussing the application of benzodiazepines for anxiety. So as you're all aware, anxiety, the term anxiety actually reflects a symptom, the normal human emotional response to stressful situations. Anxiety itself is not a disorder. Anxiety is closely related to another emotion called fear, and anxiety and fear tend to be responses to either real or perceived threat, either imminent, which would be fear, or in the future, which would be anxiety. And fear and anxiety are accompanied by autonomic sensations like the fight or flight response, as well as behaviors that tend to be avoidant or escape related. And as I mentioned, anxiety is normal and can be adaptive. But when is anxiety a disorder? So the core diagnostic criteria are that the anxiety is out of proportion to the actual danger and to the context. The anxiety is persistent, and each of our disorders has a time specifier in the DSM. For instance, for generalized anxiety disorder, symptom duration is about 6 months. The anxiety is also clinically significantly distressing or impairing. So not just is it out of proportion, but it is causing either significant distress or problems in one's functioning. The adult anxiety disorders include specific phobia, which is a fear of a specific object or situation, social phobia, which is a fear in social situations, panic disorder, which is a fear of future panic attacks in one who has panic attacks. And generalized anxiety disorder, which is a little bit different from the first three, in that it's more worry-based as opposed to phobia-based. So these are the 4 that we'll be talking about today. And in general, the way that one might use a benzodiazepine for anxiety is to reduce the physiological sensations of anxiety. These are important medications in reducing how anxiety feels, and they act quickly as opposed to something like our antidepressants, which take time to work. These are medications that can give acute benefit. So first, we'll talk about specific phobia. And as I mentioned, this is a fear of a specific object or situation that will almost always cause the fear or anxiety and is almost always avoided or endured only with intense anxiety. And there is a disappointing lack of literature on the treatment of specific phobia in terms of pharmacological interventions. Exposure and response prevention has excellent clinical evidence, and it's considered the first-line treatment. But when we review the literature for alternative pharmacological agents, things that are medication-based and not cognitive behavioral therapy-based, there are actually very few studies. I could come up with a handful of studies on SSRIs that suggested a possible benefit, but very weak data from case studies, small pilot trials, and a single small randomized control trial. There's also some studies on propranolol, which showed insufficient evidence to support its use, and only a single randomized control trial for quetiapine. So the alternatives to benzodiazepines are few and not evidence-based. But actually, even benzodiazepines have not been extensively studied for specific phobia. What we know is that as-needed dosing can be helpful for a phobia that can be anticipated or is likely to be endured. So that's something like going on an airplane trip or having an MRI or a blood draw, something that's planned. Generally not useful for simple object phobias or things that cannot be anticipated, like a fear of bees, right? But as I said, unfortunately, there's not a lot of data to support use of alternative medications. And so if one were to use pharmacological interventions for specific phobia, benzodiazepine would probably be the treatment of choice. And the best application would be as needed in a situation that is likely to be endured. A social phobia, there's a good deal more data for us to dig into. Social phobia or social anxiety disorder entails a fear or anxiety about social situations in which one might be scrutinized or negatively evaluated. And these situations are usually avoided or endured only with intense fear or anxiety. Now, this is a network meta-analysis that compared different interventions for social anxiety disorder, okay? This was not only pharmacological interventions here in this bottom half of the panel, but also psychological interventions. The waitlist control was used as their reference point. And benzodiazepines were more effective than the waitlist control. You can see that as compared to their least effective treatment, their placebo. I guess that's not a placebo. As compared to the waitlist control, benzodiazepines were more effective, but they were no more effective than the placebo pill here. You can see that there's an overlap in the standardized mean difference, and they were no more effective than the other pharmacological interventions. And if we specifically look at SSRIs and SNRIs, you can see that benzodiazepines were no more effective than those. Right. In another meta-analysis of benzodiazepines, benzodiazepine treatment resulted in more responders versus placebo. So they were more effective than placebo. And there was no difference in the relapses or in dropouts due to adverse effects, which suggests that they're effective for symptom control, not necessarily for relapse rate, and they're well tolerated. if we break these data down a little bit more, so these are the data that informed that summary slide in the previous slide. You can see that the total Leibowitz social anxiety scale score was better in patients treated with benzodiazepines as opposed to those receiving placebo. And this was true the total score, as well as the Leibowitz has an avoidance subscale and a fear subscale, and that was also true. So benzodiazepines were helpful for symptom reduction. The next slide is very interesting because it shows us, though, that although benzodiazepines are helpful for symptoms, they actually confer no benefit for functional disability. So here we're looking at how patients respond to benzodiazepines for their work functioning, their social functioning, and their family functioning. And you can see that benzodiazepines were no better than placebo, meaning that although they help with symptoms, they're not helpful for functioning. Benzodiazepines reduce symptoms, they're well tolerated, but they don't help with social functioning. How does this compare to SSRIs, right? So these are the same analyses performed with SSRIs. So SSRIs were more effective than placebo for response rate. So more patients responded to SSRIs than to placebo. There were fewer relapses. Now compare this to benzodiazepines, which did not improve relapse rate. SSRIs reduced relapses. And in this meta-analysis, SSRIs were the only drug class to reduce relapse. However, there were more dropouts due to adverse events. So that suggests that they're effective but less well tolerated than placebo. All right, now again, this is a reduction of symptoms for social anxiety symptoms in patients treated with SSRIs. And again, we see that SSRIs confer benefit over placebo for treating symptoms of social anxiety. And here it's almost imperceptible, but it's true that there is a reduction in functional disability in the work subscale, the social subscale, and the family subscale in patients treated with SSRIs. So SSRIs reduced functional disability versus placebo, and that's distinct from benzodiazepines. And importantly, this was the only drug class in this entire study that reduced functional disability. So in summary from this meta-analysis, benzodiazepines and SSRIs are both effective at reducing symptoms. Only SSRIs reduce the relapse rate. SSRIs improve social functioning while benzodiazepines do not. And benzodiazepines are better tolerated while SSRIs are less well tolerated. So that's kind of a summary of how we compare our SSRIs to benzodiazepines for social phobia. And one other consideration is, do we ever combine these treatments? In this study, patients were treated with sertraline for 10 weeks. These are patients who had social phobia. And those who did not respond after 10 weeks were randomized to receive either placebo here in blue or clonazepam here in red. Okay, and then we observe their symptom over the following 12 weeks. Subjects who received clonazepam showed an improvement in their social anxiety symptoms as compared to those who received placebo. So this suggests that the addition of clonazepam was helpful for symptom reduction when an SSRI alone was not enough. So taking together the, the several studies that I reviewed, there's inconsistent evidence to support the efficacy of benzodiazepines for social anxiety disorder, right? That first meta-analysis that we looked at did not show that benzodiazepines were any better than either placebo pill or the other drug classes, although the second meta-analysis did suggest superiority over placebo. The alternatives to benzodiazepines, you should consider SSRIs as effective, although they're probably less well tolerated than placebo. And given the overall side effect profile, cognitive behavioral therapy should be considered first-line treatment. If you are to prescribe a benzodiazepine for social anxiety disorder, what should you keep in mind? Okay, so the cases I would recommend considering a benzodiazepine or when cognitive behavioral therapy and or SSRIs are not appropriate. When would this be? It could be patient preference against or limited access to cognitive behavioral therapy because there are barriers to treatment with CBT. And if there's a contraindication to or a prior failure of SSRIs or SNRIs, one could consider a benzodiazepine. You may also wish to consider a benzodiazepine when monotherapy with an SSRI is insufficient, right? There was that study showing that the addition could be beneficial. Importantly, there are no benzodiazepines that are FDA indicated. So this would be kind of at your discretion to use something off-label. And some interesting cautions for using a benzodiazepine in someone with social anxiety disorder. They actually, because they can cause sedation or disinhibition, they may worsen social performance. So this may be a little bit counterintuitive. But somebody who may be in social situations and uses a benzodiazepine may find themselves either being too sleepy to perform well or being more disinhibited, making their social performance worse. Now let's take a look at the use of benzodiazepines in panic disorder. Okay, again, as a quick reminder, panic disorders, patients have panic attacks and then are persistently worried about having future attacks or their consequences, or make significant maladaptive changes in their behaviors related to the attacks. So first, we'll start with a meta-analysis of the pharmacological interventions for panic disorder. I have here both the efficacy and acceptability of all of these medications. And we'll look at benzodiazepines first. We see that benzodiazepines are effective as compared to placebo for treating panic, and they have an acceptable side effect profile. They're well tolerated. But how does this compare to other drug classes? So here we have at the top benzodiazepines. And if we look, we don't see any significant superiority over the other drug classes, with the exception of reboxetine, which is not considered effective for panic disorder. Benzodiazepines are probably better tolerated than some of the other alternative medications, but not consistently so. For instance, venlafaxine is also considered tolerable in this assessment. In another systematic review of benzodiazepines, which didn't have any good primary figures for me to show you, there's no difference between antidepressants and benzodiazepines in terms of the response rate. Okay, so now we're comparing antidepressants and benzos. And there was a very small benefit for benzodiazepines when compared to antidepressants for dropouts due to any cause. So what this shows us is that benzodiazepines are probably not more effective, but probably better tolerated than antidepressants for panic disorder. Here's another meta-analysis. And now we're doing a comparison of benzodiazepines to SSRIs, specifically SSRIs, not just all antidepressants. So when compared to SSRIs, benzodiazepines were not superior in failure to respond. So the response rate was similar. Dropouts, failure to remit, panic symptoms, or dropouts due to adverse events. So in summary, that means that benzodiazepines and SSRIs were similar in their efficacy in terms of response remission rates and total symptoms. And they were similar in dropouts for all reasons or for adverse events. Another study compared head-to-head benzodiazepines and an SSRI. And this was specifically clonazepam versus paroxetine over the course of 8 weeks. This was an open label trial. Although it was randomized, it was naturalistic, and patients were randomized to receive either clonazepam or paroxetine. And the naturalistic aspect of this is that the prescriber was able to select an appropriate dose. After 4 weeks, the clonazepam group had significantly fewer panic attacks than the paroxetine group, but at 8 weeks, the number of panic attacks was similar. So what this shows us is that there's maybe an early advantage of clonazepam, which diminishes, the advantage diminishes at 8 weeks. And in terms of adverse events, there were fewer adverse events in the clonazepam group than in the paroxetine group at the end of the trial at 8 weeks. But of note, these were the adverse events tended to be mostly tolerability related. So in summary, benzodiazepines are effective for the treatment of panic disorder. It's pretty consistent among all the studies that I showed you, but they're not more effective than SSRIs. They probably work faster. That was what I showed you on the previous slide, that there was advantage at 4 weeks versus SSRIs as compared to at 8 weeks, probably not superior. Benzodiazepines are well tolerated in short-term studies, and that's probably better tolerated than SSRIs. So if you were to choose to prescribe a benzodiazepine for panic disorder, what should you consider? The FDA-approved agents are alprazolam and clonazepam. As I mentioned, they have a comparable efficacy to antidepressants, but the majority of patients require longer-term treatment, which is something to consider. This is probably not a short-term treatment. They can be useful in combination with antidepressants. I showed you that that study for social anxiety disorder, but we can also consider an adjunctive treatment of a benzodiazepine in someone taking an antidepressant. And one particularly useful application would be to prevent activation side effects. And something very important to consider in a patient with panic disorder is that as needed or PRN dosing may actually be detrimental. And that's because patients may use this as a way to avoid feeling anxiety or even avoiding situations that make them feel anxious. We'll talk a little bit about cognitive behavioral therapy and how this may interfere. Benzodiazepines may interfere later. Finally, I'm going to talk with you about generalized anxiety disorder. Generalized anxiety disorder probably has the most controversy in the literature about the role for benzodiazepines. Just as a very brief reminder, generalized anxiety disorder is characterized by excessive worry and anxiety that is difficult to control and is associated with somatic symptoms. And like I said, there's some controversy here. So most of the guidelines I came across did not select benzodiazepines as first-line choices for treating GAD. So that would include the World Federation of Biological Psychiatry, the British Association for Psychopharmacology, and the Psychopharmacological Algorithm Project. However, I did come across 2 treatment guidelines that advocated for benzodiazepines as first-line agents, and that those references are all here. So let's kind of delve into the data and see what these controversies are. First, let's review this network meta-analysis of the pharmacological treatments for GAD. This is from a Lancet study in 2019. And here we see that benzodiazepines are effective and more effective than placebo for treating GAD. However, they are less well tolerated than placebo in terms of their side effects. How does this compare to the other medication classes that were studied here? You can see that probably benzodiazepines are not superior to other classes. It means that the confidence intervals overlap. In terms of acceptability, they're possibly less acceptable than some medication classes. For instance, pregabalin, the brand name for which is Lyrica, does not overlap with the confidence interval for benzodiazepines. So they may be less well tolerated, if anything, not better tolerated than other drug classes. Right, now, this is another meta-analysis. This is ranking benzodiazepines SNRIs and SSRIs in terms of the effect size for treating GAD symptoms. The benzodiazepine kind of summary data, this first diamond, SNRIs here as the second, and SSRIs here at our third diamond. Then they do an overall assessment to say, are these drugs as in combination as a class, is pharmacology better than placebo? So the answer to that last question, yes, medication treatment is effective for treating GAD. Probably, although maybe not substantially significant, benzodiazepines appear to be a little bit more effective than SSRIs and SNRIs. Although, like I said, this is not statistically significant. So based on these studies, we can conclude that benzodiazepines are effective in the treatment of GAD. And many studies demonstrate their tolerability, not all of them, but they're generally well tolerated. But this should be distinguished from safety. We'll talk about safety of benzodiazepines in subsequent slides. But when we talk about adverse events, most of these studies are talking about how well a patient tolerated the medication. There were few studies to assess the long-term risks. And as alternatives to benzodiazepines, first-line agents should include SSRIs, SNRIs, and pregabalin. If you select a benzodiazepine for treatment of GAD, here's some things to consider. The FDA indicated benzodiazepines are alprazolam and clonazepam. Selecting a low-potency, long-acting agent will be less likely to cause dependence and interdose rebound symptoms. And although some patients can improve with short-term treatment, most require long-term treatment because they'll have recurrent symptoms after discontinuation. All right. This I'm not going to read to you, but it's just here is kind of a reference to give you a template for, these are the benzodiazepines for anxiety disorders, and kind of some commentary on how quickly they start working and what their half-lives are in order to maybe select an appropriate agent for your purpose. Let's move on to talk about insomnia. So I'm talking about primary insomnia today, which is poor sleep quantity or quality, despite the opportunity for sleep that occurs at least 3 times a week for at least 3 months. And now you'll note that this is subjective dissatisfaction and doesn't include an actual number of hours of sleep or any kind of actual metric for what qualifies as poor sleep. So what are the current treatment guidelines for insomnia? What do they say about benzodiazepines? There's actually some controversy here as well. The American College of Physicians says that there's insufficient evidence to support benzodiazepines for insomnia, so they're a do not use. The European Sleep Research Society in 2017 recommended benzodiazepines as a second-line intervention. Their first-line intervention would be CBT for insomnia, and they also suggest Z drugs and sedating antidepressants in that second-line category. Now, the American Academy of Sleep Medicine in 2017 actually suggested triazolam for sleep onset insomnia, temazepam for sleep onset and sleep maintenance insomnia. Okay, so you can see that there's quite a range here, ranging from not recommended to recommended as second line and finally as first line treatment. So let's kind of review the data ourselves and come up with some guidelines. In a 2022 network meta-analysis of insomnia drugs, there was insufficient evidence to support the prescription of benzodiazepines in long-term treatment. So most studies for insomnia are short-term treatment. Now, this is a very straightforward, self-explanatory slide. I'll just let you take a look at it, and then we'll move on. I'm kidding. I've summarized it here. This is the same 2022 meta-analysis. Now we're talking about the short-term treatment, right? Because there was really no sufficient data to analyze about long-term benzodiazepines. Okay, so for short-term use, benzodiazepines were more efficacious than placebo in the acute treatment of insomnia. But there was no data to support the long-term treatment, and they had more side effects than placebo. So effective in the short term, no sufficient data for the long term, and had more side effects. This is this same network meta-analysis. And although there was some benefit shown for benzodiazepines, the results tended to favor different agents, including lemborexant, which is an orexin receptor antagonist, as well as escitalopram. They said these agents have the best profiles in terms of efficacy, acceptability, and tolerability. Although escitalopram could have substantial adverse events, which should be taken into consideration. And because it's a newer agent, safety data on lemborexant were inconclusive. So their recommendations were not a benzodiazepine, but rather a Z drug, escitalopram, and lemborexant. In a 2023 network meta-analysis of insomnia drugs, they compared drug classes and individual drugs. So among the drug classes, benzodiazepines were not superior for subjective or objective sleep onset latency, and they were worse than other classes for subjective and objective total sleep time. And there was low certainty evidence supporting worse adverse events for benzodiazepines. So as a class, benzodiazepines were not better than others for sleep onset latency. They were worse for total sleep time and worse for adverse events. When we look at individual drugs in this study, benzodiazepines were among the least effective agents, and there was some evidence that they could cause harm. These are the data to support those conclusions. Again, very straightforward, easy to interpret slides. But in any case, we look at the drug classes, and here benzodiazepines were not superior to other drug classes for subjective or objective sleep onset latency, and similarly not superior for total sleep time. And again, looking at individual drugs, this is the full panel of data. I have kind of expanded on the benzodiazepines that were explored, and these medications, when taken together, were among the least effective for sleep outcomes. And this is looking at adverse events, and in this network meta-analysis, there were worse adverse events for benzodiazepines. Here, these are the data that supported that for worse adverse events among benzodiazepines. So in summary of the study, benzodiazepines, like I said, were not favored. Rather, they supported Z drugs because they were among the most and moderate effective drugs for insomnia, although they were generally more harmful than placebo, but not more harmful than other drug classes. They also supported the use of orexin receptor antagonists, which were generally effective compared to other drugs, and were among the least harmful. So actually, these data were very similar to those from the prior study. So let's take all of these data on insomnia together, and how do we synthesize them? Although some guidelines recommend the use of benzodiazepines, and there is some evidence for efficacy, this is inconsistent. They're not consistently superior to other drug classes, and they have a high burden of side effects. So alternatives to consider should include cognitive behavioral therapy for insomnia. And if you want to consider pharmacological interventions, the data most highly support orexin receptor antagonists, particularly lemborexant, and Z drugs, particularly escitalopram. If you are going to select a benzodiazepine, the FDA-approved agents are these that I actually use very infrequently. Escitalopram, flurazepam, diazepam, temazepam, and triazolam. And then the off-label agents are alprazolam, clonazepam, and lorazepam. Similarly to one of my previous slides, I have a chart here describing the onset of action and the half-life of different agents. So some things to consider when selecting a medication would be a faster onset helps with initial insomnia, but it may result in kind of subjective experience of pleasure or a rush, and thus have a higher potential for abuse. And selecting a half-life, a shorter half-life is associated with more breakthrough symptoms. People are more likely to wake up during the night, but a longer half-life can result in next day sedation. So considering those things when you apply the very specific type of insomnia that your patient has when you select an agent. Okay, I'm going to spend the last bit of this talk talking about limitations of benzodiazepine use. We can kind of summarize them as having abuse potential, having side effects, and its potential for overdose. And finally, because we're talking about things in this case that respond to cognitive behavioral therapy, I'm throwing in this potential for benzodiazepines to interfere with CBT. So in terms of abuse and dependence, it's important to know that although this is a potential, most patients do not abuse benzodiazepines. The highest risk is among those with a history of substance use disorders. And in those who do not abuse benzodiazepines, there's still a very real potential for physiological dependence. And this can lead to discontinuation symptoms like rebound insomnia and anxiety, and even withdrawal with chronic use. And it's really important to recognize the rebound insomnia and anxiety, because those, in the cases we're talking about today, are the reasons that we're treating these patients with benzodiazepines. So withdrawing from the benzodiazepine can mimic or even exacerbate the target symptoms. Also, some caveats for using benzodiazepines are side effects, the most common of which would be fatigue and drowsiness. But there's also the potential for impairment of memory and cognitive functioning and motor coordination. Talk about this in a moment because it's even more important to consider for our elderly population, and I'll review that in a moment. And benzodiazepines can be associated with the emergence or worsening of depression. I think that's a little bit debated, but certainly benzodiazepines are not antidepressants. And so should be used with caution in patients who have comorbid depression. They may also need treatment for their depression. In overdose, benzodiazepines are generally low lethality, particularly when it's a single substance ingestion. But when combined with other CNS depressants, they become more lethal. And I will talk about cognitive behavioral therapy in a future slide. Okay, just a little bit more detail on misuse. This is a 2015 and 2016 survey on drug use in adults. And these are data reporting misuse versus as prescribed use. Okay? And they defined here misuse as using without a prescription in greater amounts or more often than prescribed, longer than prescribed, or any other use than prescribed. Okay? And we can see that overall, the rate of misuse that's here in white is generally quite low. And only in the age group of 18 to 25-year-olds is the use of benzodiazepines equal to misuse. So what this tells me is that there's generally a low incidence with the highest risk among younger adults. What are the other risk factors? So having a comorbid substance use disorder is probably the highest risk factor for someone abusing a benzodiazepine. The rate is 3.5 to 24 times higher, depending on the study. And misuse of other substances among all of these different studies is the most consistent and robust correlate of benzodiazepine misuse. Psychiatric disorder comorbidity predicts benzodiazepine use as a group of psychiatrists and mental health providers. I'm not sure that we can avoid that, but it is good to know that our patient population is more susceptible than, say, a seizure population. And exposure to a benzodiazepine prescription, which basically means if you give a patient this prescription, they're more likely to abuse it than somebody who doesn't get the prescription. Just these are kind of no nonsense summaries. Really what it means is we want to use caution when prescribing. We want to know who we're prescribing it to. Do they have a history of substance use? And recognizing that we have a vulnerable population. Yeah, patients with psychiatric disorders are vulnerable. Why does this matter? Why do we care about benzodiazepine misuse? Well, actually, there's a lot of reasons to care about this. That could be a whole lecture series in itself, but just some highlights are that benzodiazepine misuse can be associated with overdose, suicidal, or risk-taking behaviors. So that could really impact somebody's lethality, their mortality. Increased risk of infectious disease, criminality. Patients who use benzodiazepines have worse substance use disorder treatment outcomes. And generally, patients who misuse benzodiazepines have a lower quality of life. So it matters. It matters to our patients' well-being that we consider whether they'll misuse them. I'm going to spend a little bit of time talking about elderly patients in particular, because this is a very sensitive group to benzodiazepines. Now, the American Geriatric Society develops the Beers criteria, which they update and have a strong recommendation against prescribing benzodiazepines in those over the age of 65 years old. And this recommendation is strong when it comes to those with a history of falls or those using other 2 or more drugs acting on the CNS. They also, of note, placed Z drugs on the Beers criteria of list of medication to avoid. So that's to be taken into consideration for insomnia. And so why do we avoid benzodiazepines in the elderly? Well, it can increase their risk of delirium. It can increase their risk of falls and fractures. It can increase the risk of dementia and cognitive decline. Now, this is a little bit controversial. I'll show you some data on this in a moment. And it can actually increase all-cause mortality with a range of 1.2 to 3.7 times increased risk of mortality in the elderly. Okay. So in terms of cognitive decline, like I said, this is controversial. There are mixed findings on the association between benzodiazepines and cognitive decline, and the causation remains unproven. The risk factors tend to be longer acting benzodiazepines, a longer duration of use, and earlier exposure are more likely to be associated with cognitive decline. Here's one meta-analysis comparing those using a benzodiazepine to those never using a benzodiazepine and their risk of dementia. And we see that there's about a 2-fold risk of those who've used benzodiazepines in developing dementia. So we conclude that long-term benzodiazepine users have an increased risk of dementia. Again, that's not a causation. But here, this is a meta-analysis that actually tries to take into account protopathic bias. And so protopathic bias, or sometimes called reverse causation bias, is something that affects case control and cohort studies. So when a pharmacological agent is prescribed for a prodrome of the symptom or the disease that we're studying, it could kind of create an artifactual excess of cases in the drug use group. So that means that, let's say somebody who will eventually develop dementia is exhibiting anxiety or some other symptoms for which they may use a benzodiazepine. It may appear that the benzodiazepine is causing dementia when really we're showing a group of patients who are developing dementia and we're treating for that. Okay, so how does this study account for that? Well, what they do is they create a lag time where they exclude data for a certain period of time prior to disease diagnosis. So a certain window in which you disregard exposure to a benzodiazepine before diagnosis. And so when they make this adjustment, even still, there is a positive association between benzodiazepine use and dementia. Okay, and finally, like I promised, I'll give you just a couple slides on whether benzodiazepines can negatively impact CBT. So this is a very old study from 1993, and it is showing patients who responded to exposure therapy for treatment of anxiety. So these are patients who successfully responded to exposure therapy, and then we look at those, all of these are exposure cases, those who received alprazolam, that's for benzodiazepine, and those who received placebo, okay? And although all of them responded, there was a higher relapse rate in those who received alprazolam. So what that means is that the exposure itself was equally effective, whether the patient was taking a benzodiazepine or not, but long-term benefit was less robust in those who were on the benzodiazepine because they had a higher relapse rate, right? And what that could suggest to us is that patients taking a benzodiazepine are less successful at consolidating or maintaining benefits from exposure therapy. Finally, going to emphasize this cognitive behavioral therapy model that many of you are familiar with, particularly if you've been to any of my other lectures or if you're familiar with the Anxiety Disorders Clinic. So in terms of cognitive behavioral therapy, we think about thoughts, feelings, and behavior. It's kind of how we would characterize anxiety disorders. And anytime you use CBT to treat an anxiety disorder, what we're trying to do is improve somebody's ability or willingness to feel anxious and their willingness to engage in anxiety-provoking situations and to decrease avoidance. And when people use a benzodiazepine, we actually consider it a part of their behavioral coping because people use benzodiazepines to feel better, to reduce the feelings of anxiety. And it becomes a way of coping that interferes with exposures, a willingness to expose themselves to anxiety-provoking situations, and an increase in avoidance, avoiding feeling anxious. And so particularly in patients who are in cognitive behavioral therapy, I would think twice about prescribing a benzodiazepine. I'm not going to spend too much time on deprescribing benzodiazepines, but certainly something that I would advocate for in elderly patients and those who are no longer receiving benefit or who don't have benefit or who are exhibiting side effects, okay? And then I want us, before I end, I would like for us to do a quick summary and then get back to that case study. Okay, so in terms of anxiety disorders, I don't recommend benzodiazepines for specific phobia. For social phobia, I would consider it among a second-line choice when an SSRI or CBT is either not available or insufficient. For panic disorders, benzodiazepines are better tolerated and work faster, but they're not better, more effective than SSRIs. And for generalized anxiety disorder, I would consider them second-line agents. Okay. And for insomnia, they're not first-line treatments. Instead, I would consider CBT for insomnia as a first line. In non-elderly patients, you can consider Z drugs and as another alternative, orexin receptor antagonists. And let's wrap up with our case. Okay, so this is our 35-year-old woman with depression and treatment refractory GAD with her initial GAD-7 score of 18, coming in having failed treatment with fluoxetine and diazepam. We increased her dose of diazepam to 10 milligrams twice daily, and she experienced substantial improvements in her symptoms of GAD. So she had improvement in her muscle tension, restlessness, insomnia, energy, and her ability to relax, with almost halving of her GAD-7 score. She did continue to have excessive worry, so we note that this helped with her physiological sensations of anxiety, but not the cognitive experience. And she returned to CBT for further symptom management. And the clinical pearls from this case study are, this patient was appropriate for a benzodiazepine because she had failed numerous alternatives. You know, we really couldn't say that there was any better choice for her. So this included first and second line agents as well as adjunctive treatments. And in her case, she tolerated the benzodiazepines better and they were more effective. She was a low-risk patient in that she didn't have any history of substance abuse. She was not elderly. We tried to maximize benefit by using a longer-acting benzodiazepine and a standing dose instead of PRN dosing. We'd also just appreciate that she had a fear of dependence. So not only are we as practitioners, worried about dependence, patients also have this concern. And finally, just a little bit of additional pearl here. This is a patient who's pursuing pregnancy. So a little bit about benzodiazepines in pregnancy. There's no increased risk of miscarriage in pregnant women who use a benzodiazepine. There's some conflicting evidence on congenital malformation. Older data suggest a less than 1% risk of cleft lip and or palate, but the newest studies suggest that they do not cause congenital malformations. There's some inconsistent evidence on the increased chance for preterm delivery, low birth weight, and or smaller head size. So these are all things to discuss with a pregnant patient. And fetal exposure to benzodiazepines late in pregnancy might result in a withdrawal syndrome in the infants after delivery or within several days of birth, which is also something to consider. And I believe that's all I have for you. I apologize I didn't leave too much time for questions, but I so appreciate your attention, and I'd be very happy to answer a few questions.
Yeah, thank you so much, Margaret. Yeah, we did have a good number of questions come in, so we'll try to get through as many as we can before noon. One of the questions was asking about overlap between anxiety diagnoses, given just what we know about the comorbidity between different anxiety diagnoses, and asking how did the studies delineate efficacy of benzodiazepines in one disorder over another, such as finding benefit with panic disorder, but not for social anxiety, for example.
Right. So that's a great question, and really gets to the difference between a clinical practice, what we see clinically versus what we see in study populations, because clinical trials tend to rule out patients who have comorbidities. So they're looking at pure patient populations. And so unfortunately, we're probably not looking at patients in these studies with multi-morbid anxiety. It also, I think, speaks to why our clinical experience may not be as clean as what we see here. But what I would say is that if you see somebody with comorbidities, you can probably consider that a benzodiazepine may be helpful for some aspects of their anxiety, but not others. For instance, if you have a patient who has panic disorder and social phobia, you may expect that their panic disorder symptoms will get better, that the physiological sensations will get better, but that perhaps they won't have improvement in their social functioning. So maybe kind of recognizing that there will still be limitations. But that is very hard for me to answer with kind of clinical evidence because those studies unfortunately don't exist.
I think that the last question, hopefully maybe captures two birds with one stone. We got a couple questions about the deprescribing aspect and kind of the challenges that present when it comes to patient buy-in there, patients saying they're perpetually not ready, somebody saying like, I'd rather have a benzo or a different doctor. Any thoughts on your end about like how to have that conversation?
Yeah, thank you so much for that question. Now, this is a really like a nuance, and I'd be very happy to talk offline about this. What I would say is that if somebody is coming to me with a poor control of their anxiety or side effects, I really emphasize that I don't think that this medication is working for them. Right? So if we are as clinicians making a decision to take somebody off of a benzodiazepine, presumably we have a good reason for it, right? And I highlighted some of the good reasons for that. If somebody is in a high-risk population, I brought the slide back up. If it's not working for them or they're having side effects. And I would really emphasize that in the conversation and say, I am making this recommendation because your anxiety is still active. Mm-hmm. And if you're going to be taking medication, I want it to be working for you. And I want us to find something that does a better job than this one. I know sometimes that can be very difficult. And in terms of buy-in, sometimes it's a matter of trying to find other medications that might help. So what I like to do is say, this is going to be our long-term goal. I draw kind of a timeline out and say, in the long term, I want us to get you off of this benzodiazepine. And in the short and medium term, I want us to get your anxiety under better control. Let's get you into cognitive behavioral therapy or maximize your antidepressant, maybe try some adjunctive treatment, some neuromodulation that you haven't tried before. And then somebody who's feeling less anxious and their symptoms are better controlled may be more willing to come off of the benzodiazepine.
Well, thank you so much for this really wonderful talk. It was really a fantastic distillation of the state of the evidence right now. And thank you all for being here, and have a good rest of your day.
Thanks so much. If it's possible, I don't know if it's possible to kind of save these questions that have popped up. I'd be very happy to respond offline, shoot you an email or something about with some answers to them. Be very happy to do that.
Yeah, I think there's a way to, so I can get them to you after this.
Okay, awesome. So I will I'll look forward to communicating with some of you offline.
Thanks so much.
Thank you.